we haven't already done so. I'd now like to introduce our webinar chair, and that is Professor Bridget Lum. Bridget is Professor of Systems Neuroscience at the University of Bristol and was recently President of the Physiological Society. We are therefore very fortunate to have her as a trustee at Brace, where she chairs the Scientific Advisory Committee. And that's an important role because the Scientific Advisory Committee, or SAC for short, vets all the incoming applications we get to make sure that they are scientifically sound before the trustees decide whether or not they can be funded. We're also very fortunate to have her as our chair this morning. So, Bridget, can I hand over to you, please?
Good morning, everyone, and welcome to this webinar on the important topic, COVID-19 and the impact of dementia, impact on dementia research. Now, the COVID-19 pandemic has had profound effects on many strands of medical research, and not least research into mental health, including dementia. These effects continue and are even increasing. And the detrimental effects on dementia research come in different guises. The first is a very logistical one, in that strict social distancing measures mean that many of our researchers have been locked out of their laboratories, and others who work directly with patients are not able to continue their clinical research. Furthermore, many clinical researchers who work to improve care for people with dementia are also clinicians or nurses, and with the NHS under great strain, many have had to join the fight against the virus itself. The second concerns funding for research. Brace, along with other charities, has been hit hard by the crisis. We've had a 60% drop in income and are increasingly having to turn down good research for lack of funds. As chair of the Scientific Advisory Committee, I am very aware of this. Thirdly, and not yet fully realised, is the long-term impact the pandemic has had on mental health itself. These are all extremely important questions to which we all want some answers. So to help us understand the real impact COVID-19 is having on dementia research, Brace has assembled a panel of experts from across the dementia disciplines. So I welcome you all, and I'll introduce them in the order they will present, and then we'll listen to their presentations. Okay, so the first presentation will be from Professor Tony Baer from Cardiff University, where he is Professor of Geriatric Medicine and Chair of the School of Medicine. And Professor Baer's research interests include clinical management of cognitive disorder and neurodegenerative disease, especially Alzheimer's disease. He is Director of the Memory Assessment Service in Cardiff and Vale University Health Board, and a member of numerous national and international bodies concerned with ageing and older people, including the Public Health Committee and Research Grant Advisory Board of the Alzheimer's Society. After him, there is Professor Clive Ballard, who is Pro-Vice Chancellor and Executive Dean of the University of Exeter. Now, Clive is a psychiatrist who was driven to study dementia after witnessing the poor conditions in which people with dementia were cared for. He has led or co-authored over 600 research papers and attracted grant income in excess of £150 million over his research career. Professor Ballard has won several awards, including the Western Brain Institute Outstanding Achievements Award, and has led more dementia and cognitive health trials than anyone else in Europe over the last decade. And for this, he was featured in the Lancet Neurology for his achievements. Now, Professor Ballard is obviously a very busy man, and perhaps not surprisingly, can't be with us in person today. However, he has very generously pre-recorded his presentation and nominated a colleague, Byron Crease, who is a senior lecturer at the University of Exeter Medical School. Brian's own research focuses on the relationship between new onset psychological symptoms and cognitive decline in older adults, as well as the molecular mechanisms and treatment of symptoms like those in dementia. Byron is currently leading a study tracking the mental health of over 4,000 adults aged over 50 during COVID-19. So we're very pleased to welcome Byron today. The final presenter is Dr. Thomas Welsh from Bristol Medical School. And Dr. Welsh is Deputy Chair of Dementia Specialist Interest Group of the British Geriatric Society and a member of the European Geriatric Medicine Society and Deputy Director of Research Institute for Care of Older People, where he's a consultant. We're very pleased to welcome Thomas, who is co-author of a recently published article, COVID-19 in Older People, a rapid clinical review. So I'll introduce each of these speakers in turn to give their presentations, and then, as Mark has already said, I'll chair a question and answer session at the end of the talks. And I hope you've now discovered where to find the chat line, where you can post questions during the talks. And at the end of the talks, the chat line will be monitored by two of my colleagues. That's Amanda Cole and Emma Bone, who both work with Brace, who will flag your questions to me when I can introduce you to pose those questions. So let's get started and welcome the first speaker, who is Professor Tony Baer. Hello, Tony. Good morning.
Well, thank you for the introduction. Thank you for the invitation to speak. Perhaps I should update the introduction that in fact I semi-retired at the end of last year, so I fortunately have given up managerial and most clinical work, but I hopefully remain active in the area of dementia research and policy. That's always been my major enthusiasm. Also, I just have to take the opportunity to thank Brace for its support over the years for our research with Professor Andrea Tales in Swansea. That it's certainly been very helpful and much appreciated. Now, I'm not going to have a PowerPoint slide you may or may not be happy to hear, and I'm going to talk more about my general experience of the impact of COVID on dementia research during the first wave initially, then subsequently, and hopefully look a bit more to the impact for the future. So thinking back 12 months ago, I think it's fair to say that the impact of the first wave on dementia research was pretty devastating because everything more or less became suspended overnight from late March through April, May, and then started perhaps getting its act together and going again in June. Clinically trained staff, doctors, nurses, therapists were in general redeployed. I had to very quickly try and polish up my knowledge of acute medicine again, only to find that everything these days is done by apps and new technology that was all a bit too much for me. My research nurses involved with dementia studies went to the front line on the wards, which was a bit of a shock to some of them, and to swab people's throats at COVID testing stations. The laboratory staff, the office staff were locked out and all went home, which did have the advantage in one or two cases that data that had been waiting for analysis and papers that had been waiting to be written up finally got done. Neuroimaging studies, brain scan studies for research came to a standstill. The laboratories weren't working, so DNA extraction and so on was more or less non-existent. And people with dementia in ongoing studies couldn't come to the hospital or the research unit for assessments. People actually in hospital or care homes involved with research were of course largely isolated, uncontactable. Their relatives were left sort of outside, anxious, uninformed. So things were not good this time last year, but fortunately things subsided, and gradually through the summer, dementia research did start going again. I think one advantage of the epidemic has been that we've learnt to work better as a team. even though we're physically distanced, and we've learned to become more adaptable, more resilient. And although I can't say I was a great fan of Zoom and Teams this time last year, it has provided opportunities for communication in new ways. This meeting is a good example. The idea that 40 or 50 people would all travel to Bristol for an hour on a Tuesday morning for this sort of meeting is perhaps optimistic, whereas using Zoom, it means that we can get together, attend meetings, conferences, share research that much more easily. Zoom actually also facilitates multi-center research studies in that the centers can very regularly sort of communicate to each other, and now I think we've all got used to video conferencing, Zoom being less impersonal than it was perhaps when we first started. And it also enables, to some extent, for patient assessments and follow-up. In clinical trials, we've started to question actually why we always insisted on all visits being to the clinic. And some can just as easily be done by video conference or perhaps telephone. Now, perhaps just a quick health warning, because of course, when we're talking about dementia, when we're talking about older people, and who are older people like me now, who are less tech savvy and may not have access to internet-enabled phones or tablets or computers. Now, I think that the most recent figures do suggest that the majority of the over 65s and now use the internet, but certainly it's still not the majority of the over 75s. And we did a quick study of consecutive referrals to the memory clinic over last year, and in a third of cases, neither the patient or their carer had a suitable device, or if they did have one, they didn't know how to use it, or they didn't have access to Wi-Fi. So perhaps it's an important reminder before we start moving all studies and assessments over to electronic or virtual media, that is potentially going to exclude a third of people with dementia from the studies. By contrast, only 3% of patients or carers did not have easy access to a telephone, and that was actually largely people in care homes. So the simple, familiar telephone technology perhaps has a role, as well as video conferencing. Administering drugs in clinical trials, collecting blood samples has had to change. We're doing more with home visits. I've always been keen on home visits, but was often had to justify them from health and safety concerns and so on. But in one clinical trial that involves a subcutaneous infusion, infusing the drug under the skin, the protocol has been adapted so that it can now be administered at home under nurse supervision. And this is not only more convenient for patients and relatives, but it also potentially reduces costs, and looking ahead, perhaps makes such treatments more widely and easily available. So there are benefits. Another positive benefit of COVID has been that R&D departments and ethics committees, which I usually am happy to defend, but at times they can be a bit inflexible. But they've become more accepting of electronic or telephone consent rather than requiring everything to be done in person. They have much more open to web-based data collection and certainly much speedier decisions than in the past. So these are obviously all welcome changes that we need to make sure continue for the future. And then Bridget mentioned the impact of COVID on dementia itself, which needs to be studied. We know that COVID, that people with dementia rather, are perhaps 2 to 3 times more likely to become infected. If they do become infected, they're more likely to present atypically with delirium, acute confusion, rather than the symptoms, loss of smell and so on that we're told about. They're more likely to become severely affected, and of course, unfortunately, they're more likely to die. But the reason for the increased risk is less clear, needs to be researched. COVID also may exacerbate cognitive decline in those with pre-existing dementia, may even trigger development of dementia, perhaps through inflammatory mechanisms or effect on the small blood vessels. So there's going to be a need for new basic science research, and social and policy research also needs to be geared up. The dementia population was one of the first to go in to and the last to come out of periods of isolation. But I think what is well accepted was that this was at the cost of worsening neuropsychiatric symptoms, greater behavioural disturbance. It was much more difficult to have access to appropriate support services. Carers were fatigued. There was much more carer burnout. And so we need to think, how could and should this have been managed better? Now, another consequence of COVID has been that unfortunately some projects have had to be shelved. Some research staff have moved to other posts and unfortunately perhaps will never come back to dementia research in the future. New grant funding seems likely to be challenging over the next few years, given, as we've heard, the grant income of many organisations has fallen. And I'd encourage everybody also to remember that in the 2019 election, the government promised to double dementia research funding in this Parliament. And so I think we need to make sure that that isn't forgotten. Looking ahead, we also need to ensure that dementia research quickly gets up to full steam ahead, allowing for social distancing, other restrictions. One thing I would say is that staff enthusiasm seems to be high, and I think people are much more prepared to be adaptable and perhaps better prepared for the unexpected in the future and dealing with that quickly and effectively. And most importantly, certainly people with dementia and their relatives seem very keen to re-engage with research, and all the patients that we have asked to become involved with new studies in recent weeks, despite the various obstacles in their way, are very pleased to be asked and want to take part. And so we owe it to them to overcome all the barriers and to quickly regain momentum. So that's perhaps a general overview, and I'll hand back now to Bridget because I think the other speakers are perhaps going to talk a bit more on specifics.
Thank you very much, Tony. That was very insightful and very useful, I'm sure, and will have prompted many questions without doubt. So could I now introduce the virtual Professor Clive Ballard to give his presentation? Emerald, is it you that's setting that up, or? Here we go. So I welcome the virtual Clive Ballard, who's going to give his presentation on the challenges, opportunities and impacts of COVID on dementia research.
Thank you for inviting myself and my colleague Byron Crease to present at the BRACE conference. We're just going to give a few reflections on some of the challenges, opportunities and impacts of COVID on dementia research. I'll do the pre-record presentation and Byron will be present as part of the Q&A panel. Firstly, I just wanted to say that I think, as well as all the challenges, there have been some opportunities, and particularly in certain sort of arenas such as perhaps digital health, remote assessment. Some of those things have moved forward and there have been kind of some new opportunities. And I'll just give a couple of examples from our own work, looking at our digital nursing home training program, COVID World, and our Protect Online platform. And also using our Protect Online platform, we have been able to fully recruit for a 600 participant randomized controlled trial of vitamin D in people with early cognitive impairment, which perhaps shows the potential of those online approaches, but also has been particularly successful during the COVID period when a lot of other research has been halted. And you can see here are some of our COVID World materials, the digital materials, and this is a randomized controlled trial of virtual coaching supported with these digital materials versus usual care to try and improve sort of outcomes for people with dementia living in nursing homes at these very challenging times. Using our online Protect platform, we have 25,000 participants. A number of those are carers for people with dementia, and we've been able to start looking at profiling how their caring role and the times they spend in different types of roles has changed during COVID. And we've also been beginning to look at the impact on neuropsychological function during COVID, particularly in people with early cognitive impairment. And one of the interesting things that we've been able to demonstrate from that is that people who have been undertaking more word and number puzzles actually seem to have some protection of their cognitive function over this period. And there's a lot of fuller analysis of this work and overall cognition going on at the moment. But again, this perhaps demonstrates one of the opportunities that the platform has enabled during this time. So I think I didn't want to lose sight of the opportunities, but obviously there have also been an awful lot of challenges. There have been delays to lab-based clinical trial programs, or even where labs have started back, at least in our own university, things have to be socially distanced. There are regulations on numbers of people allowed in a lab because of the ventilation requirements. And this has really kind of slowed down a lot of work, caused a lot of delays, caused a lot of funding challenges. This is combined with bad budget challenges for many funders and for higher education. A number of charities have been particularly badly hit during the COVID crisis, and that has had a major impact. We're just seeing recently that UKRI are sort of cutting certain funding programs, particularly global funding programs. And of course, there's been major financial impacts for higher education with reductions in international students registering over the last 12 months. And this also then had the knock-on effect of reducing the capacity of higher education institutions to perhaps fill some of these funding gaps and perhaps not being able to support or sustain research in the way that ideally they would have liked. So there's a lot of impacts on actual specific research projects and on researchers delivering these and on the underlying infrastructure. And I think this will have a particularly big effect on early career researchers. And I think it's inevitable that there will be some important reduction in the number of researchers working on dementia in the short term, and that's going to be a really important problem for us to address. And also to think about what sort of mechanisms are needed to enable researchers to get back on their feet, particularly researchers at sort of early stages of career when these are particularly vital times. I think there's also been a challenge with even where funders do have money. There's been prioritisation of COVID work, which means de facto there's been deprioritisation of non-COVID work, and that's also having an impact on the available resources. I think although these things are all challenges, my own feeling is that when we emerge from COVID, we can't just talk about the challenges and the need to get back on our feet, although that's an important part of the equation. I think we have to talk about present an exciting vision of how we're going to move forward, how we're going to address some of the key challenges in the future. And I think this is a little bit about looking at what some of the key gaps and challenges are in the wake of COVID, understanding that, the critical mass of researchers, early career researchers, some of the key infrastructure that's necessary. I think reminding people of some of the exciting emergent science that has occurred during COVID, but that hasn't been COVID related. For example, there's been a lot of very exciting work about blood-based biomarkers, and I think that's something we can really build on. I think we need to kickstart clinical trial pipelines. I mean, worldwide, this is a challenge anyway, but there's been a lot of halting of clinical trials, and I think we need to present this as new and exciting ways to deliver trials. I think some of the digital innovations will really help us to do this, to build clinical trial platforms. But I think we need an exciting proposition that can really begin to address the challenge, and something that people want to invest in for positive reasons, not just because it's been a difficult period. And I think there's all kinds of other ways we can build on some of the digital and data opportunities that have emerged from COVID and not lose the developments and insights that have emerged from that kind of work. So I think it's been a really challenging 12 months. There have been some opportunities. I think there are opportunities going forward. And I really do think we need to get together as stakeholder groups and really try and present this as a cohesive stakeholder vision. There's going to be limited resources, a lot of people asking for them, and our offering, our vision has to be more exciting than that proposed by other individuals and other interest groups. So hopefully these thoughts have been useful, and thank you again for inviting us to present the reflections.
Okay, I suppose this illustrates one of the advantages that we've experienced in this COVID era, which is that Clive Ballard was able to pre-record his presentations, which we've now had benefit from. And as I say, he has nominated someone to help with the questions and answer session later. So I'll now introduce our final speaker, which is Dr. Thomas Welsh from Bristol Medical School. He is Deputy Chair of Dementia Specialist Interest Group of the British Geriatric Society. And so without further ado, Tom, thank you for being with us today.
Hello, and thank you very much for the invite. I'm just having the traditional Zoom fight with the technology now to make my presentation appear, which we did check earlier on and it worked beautifully. But now the screen is of course frozen. I'll try again.
Tom, I do have the presentation available if you wanted to say next slide, please.
Why don't we do that? We'll go to plan B. Okay. I thought it might happen, but so lovely. So I'm Tom Welsh. I'm an academic geriatrician based in Bath, and my role crosses between the Acute Trust and the Research Institute for the Care of Older People, where I'm Deputy Director, and we therefore are involved both on the clinical front, looking after people with memory problems, and of course with COVID-19, and of course involved with a number of studies, both trials of novel agents, potentially for the treatment of conditions like Alzheimer's disease, and non-drug interventional studies as well. So from that point of view, I'm going to hopefully talk through some of the challenges and opportunities that we've experienced. Would you mind going to the next slide, please? Sorry. Mm-hmm. So, as we know, the COVID-19 pandemic has profoundly challenged and continues to challenge healthcare systems around the world. And as has been alluded to earlier on, older people and people with dementia in particular have quite the brunt of the impact of this, being higher risk of hospitalisation and higher risk of dying as a result of this infection. And of course, the public health measures that have been put in place to try to reduce the impact have had, again, a disproportionate impact on people with dementia and on older people in particular, with restrictions in movement and reductions in social contact, disrupted social networks, all had an impact. And of course, non-COVID healthcare has taken a bit of a back seat over the last 12 months. And again, that disproportionately affects older people and people with cognitive problems. We have the next one, please. So on the research front, as we're all well aware, this has had an enormous impact on the ability to deliver research. So of course, when lockdown 1 came in around this time last year, as I said earlier, our studies all pretty much ground to a halt. Recruitment was stopped across the board, and a lot of mitigations had to be brought in very rapidly, particularly for participants in ongoing drug studies. So we were able to make some adaptations on that front, and we'll come to those shortly. But clearly, a great deal of flexibility was needed fairly rapidly to enable things to keep going. There are, of course, a lot of longer term worries. I mean, the economic impact of the pandemic and the public health measures is really yet to be costed, but is presumably going to have a significant effect on what public funding is available for research going forward. And we're already well aware of the impact on charitable funding, and therefore the impact on future funding streams from that point of view. Early career researchers, again, potentially bearing a bit of the brunt of the impact here, those in less long-term posts or early on in their careers, this will have had a significant impact on. We know there's been disruption to people's PhD programs, for instance, and this may end up causing a sort of a lost generation of potential dementia researchers going forward. And of course, at the moment, the healthcare service is now starting to gear up to deal with the backlog in non-COVID related healthcare, and a lot of clinical academics are still therefore being asked to prioritise delivering some of that additional clinical care, potentially having a long shadow of effect on availability for research in the future. Can we have the next one, please? So just a little bit of background. My research largely takes place in the Research Institute for the Care of Older People. This is an independent charity that provides the NHS Memory Clinic service for Bath and North East Somerset. But obviously we're very research active as well. We do a mixture of trials involving new agents and non-drug trials involving people with dementia and sort of older people in general, so not just restricted to that particular area. We have that excellent bit, thank you. And so just in terms of the trials of novel agents, so these are largely medications that have been developed for use in potentially treating people with Alzheimer's disease. These sorts of trials are very carefully developed and quite highly structured in terms of how they're done, rely quite heavily on a lot of face-to-face interactions, and often with a lot of heavy imaging requirements, often for safety reasons, so that people can be carefully monitored during these studies. Now, of course, with the impact of COVID-19 and the movement restrictions and constraints that came in, there was a huge problem with delivering some of these. So a lot of work was required to be done to put in place the necessary flexibilities and alternative arrangements for safety scanning, for delivery of medications, and for instance, for some of the trials, we were able to enable those drugs to be delivered at home by a member of the nursing team, which again enabled those to keep going and reduce that need for people to move around. But of course, there's also been a longer term impact on potential for screening and how we recruit people for these sorts of studies, with the impact on the clinical service. So I'm sure this is going to apply not just in the world of dementia research, but in most areas of clinical research, which rely heavily on recruiting through routine clinical activity. which of course has been significantly impacted by the events of the last 12 months. And I think we're going to see that that is going to continue to have a problem with recruitment to certain types of studies going forward, as we know from experience that it's much easier to recruit someone you already have a good rapport and relationship with in the clinic. Trying to recruit people more indirectly is often less effective and less attractive for people when we're trying to get people involved in these sorts of studies. You have the next one, please. Just to counterbalance that, an example of a non-drug study, we've been involved with this NIHR-funded study for a few years now. It's called PRAISED-2 study. It's a study that looks at using a physiotherapy intervention to help people with mild dementia or mild cognitive impairment to remain independent. And this study has involved a lot of face-to-face work with our therapists visiting people at home very regularly to provide ongoing support with their therapy interventions. So COVID had a particularly and specific effect on this study because suddenly we were unable to deliver those face-to-face sessions that were an important component of this intervention. That's partly where the technology came to the rescue, as it were, in that we were able to do a mixture of telephone and video contacts with participants and their families to try and maintain some of the therapy intervention over particularly the strictest periods of lockdown. And a lot of work was undertaken to look at how we could enable this study to continue in light of expected further waves of infection, which of course have subsequently come to take place. And with appropriate mitigations and appropriate PPE and appropriate consent from participants, we were able to restart some of these home-based interventions for participants in this particular study. And I think obviously that did carry a bit of a risk in that there was a risk of people visiting people at home, potentially introducing infection there, but also a huge benefit for participants. So often this was the only interaction with someone not in the immediate family, face-to-face, that people had experienced over this 12-month period. So it's been a bit of a lifeline for people involved in this particular study. I think, as with everything in life, there's always a balance of risks and benefits, and hopefully we've got it right with this particular one. The next one, please. So just thinking ahead and delivering research for people with dementia, well, as was mentioned right at the very start, traditionally a lot of our interactions have been done face-to-face, and the events of the last year have really made us look at that closely and say how many of these things need to be done face-to-face, how much of this could actually be done a bit more flexibly. And although video conferencing tools are not for everybody, as I've demonstrated nicely this morning by being unable to do my slides, they can be very helpful, and it just provides that extra bit of contact. We've been using some of these tools clinically with the memory service as well, and it's not for everybody, of course, and for some people it's never going to work as well, but for some situations and some circumstances it can really just make things a bit easier to achieve. As was said before, you know, a fairly significant proportion of older people may not have access to this sort of technology, and that does risk excluding people from ongoing research. And of course, people who have a degree of cognitive impairment or potentially sensory impairment, a video or telephone interaction just may not work as an option. So I think we've got to be flexible looking at these things going forward. And I think this is where it's really important to have early PPI, patient and public involvement, in the design and delivery of these sorts of studies, because these are exactly the sort of areas where advice from people in the know is going to be so very important. As I said earlier, the disrupted clinical services are going to pose a problem to recruitment going forward, and I think it's going to be necessary to broaden and perhaps try some novel approaches to recruitment for studies, perhaps using slightly alternative approaches such as webinars, for instance, to try and broaden interest and make people aware of what's going on. And I think earlier we alluded to things like doing e-consents or consents over video, just to try and reduce the need for those face-to-face interactions And I think that may well be a good way forward with some of this. Next one. So as I was saying, restrictions to clinic visits and visits to hospital sites are likely to continue at least for the next year or so. So I think for future research and for research that's going on at the moment, there just needs to be a lot of resilience built in and a lot of flexibility built in. So use of technology where appropriate, doing things at home where possible. People taking part in research love that anyway. It always goes down well to avoid an unnecessary trip out of the home to somewhere else, and using different approaches. So, for instance, with the PRAISE study that I mentioned earlier on, we moved to using a lot of additional postal questionnaires to avoid people having unnecessary journeys, and just looking at how we might be able to embed routine research assessments in routine clinical practice. I know in other centres and other parts of the world that there has been a definite move in that direction, particularly with increased use of electronic records, and that really does enable research to occur without additional time and additional visits. And I think that's going to be really important. And as was mentioned in Professor Ballard's talk, proper digital dementia platforms are going to be key to some of this. Next one, please. So just to try and pull that together, I mean, as we're all very well aware, coronavirus has had a profound and an ongoing impact on research and, of course, on clinical activity and on the world at large. From the research point of view, support and flexibility for ongoing projects is really required. And future funding is a real worry. It's clearly vital that dementia research is appropriately supported going forward. And as was mentioned earlier, this promise from the government that funding would be increased over this Parliament, I think needs to really be held in there. Very, very important. Future studies need to adapt, be flexible, greater collaboration. And that's one of the areas that coronavirus research has shown us, is that rapid collaboration from multiple sites is really important and really does deliver good quality research and outcomes that we all really want. And from the research perspective as well, I think it's important that we do have studies and projects looking at the care of people with dementia as well as looking for cure, because although we're all really desperate to find curative treatments for these conditions, it seems extremely likely we're going to be looking after people with dementia and related conditions for many, many, many years to come, and good research that underpins good care is really vital on that front. People with dementia, the impact of this has been huge. There's been loss of access to healthcare, to social networks, to all those supportive measures that are there that keep people and their dementia functioning as good as possible. And from a researcher point of view, I just want to highlight again the impact on early career researchers and that potential loss of future funding, and how we try and mitigate against that and support people going forward. And thank you, that's me done.
Thank you very much, Tom. And so I'll now thank all our speakers and open it up for some questions and answers from the audience. If you'd like to do that via the chat line, and they'll be flagged to me by Emma and Amanda. Well, perhaps whilst we're waiting for questions to come in, I'll kick off. And I was quite interested, Tom, if we start towards the end of the talk, I suppose, your comment about the need for research into into appropriate care for those with dementia rather than a cure. Can you see obvious areas where you would like to see investment into this type of research?
Well, I mean, one of the areas which is an area which is commonly a clinical issue that's come across very commonly is how to manage, for instance, distress in people with significant cognitive impairments, often people resident in care homes. And at the moment, there isn't really a satisfactory evidence base for how we approach someone like that, how we assess them, And I think developing a systematic approach to managing that sort of presentation would be very valuable.
Okay.
And it's a problem, that's routinely encountered, and we often get phone calls from general practitioners or people we're asked to see ourselves as geriatricians, particularly in care homes, where there's obviously a problem. A person is distressed. But what is the best way of managing that situation? I think it's unclear at the moment, and I think that's an area that's really calling out for good evidence behind it.
Thank you, Tom. And do let me ask the other speakers to ask questions of each other. And can I reintroduce Byron Crease from Exeter, who's here to field questions that perhaps are connected with, well, more generally, but also those connected with the presentation we had earlier.
Could I jump in there on the topic of care homes, if that's...
Yeah, sure, Byron.
Yeah. Just a reflection on some research that we've been doing, and Clive mentioned in his talk that we were able to sort of digitize a previous in-person program of psychosocial support for people in care homes, which has been something that has been funded through COVID research, specific COVID research money from the government, which is great. I think that doesn't take away the challenges of doing research in care homes at this particular time. So the tricky thing is that even as we get better protection through the vaccine, care homes are still run off their feet, and research, certainly some types of research anyway, it's frankly and understandably fairly low down on their list of things they want to get involved in. There's the issue of, they have quite a high staff turnover anyway, but added to that, needing to self-isolate and so on with infections going around care homes. I think, so I don't know if there's an easy answer to this really, but it's just to highlight the ongoing challenge of trying to do research in care homes in the current environment, even as it stands now. It was basically impossible a year ago. We're getting back into care homes, but there's still a need to, it's still up to the care homes. They make the decisions about the research they participate in, and understandably, sometimes it's a low priority. And I'm not sure there's an easy way around that, or whether it's, or how to address it, but I just wanted to kind of bring it up really.
Yes, thank you very much, Byron. That's helpful. Oh, Tony, off you go.
I can just say, there's always been a problem that people tend perhaps to be very risk averse, unnecessary risk averse, and not see the advantages of taking part in research. And that's been a barrier to nursing home and care home research always in the past. Now, as Byron says, it's well nigh impossible to get into involve care home residents with dementia in research at the moment, unless it has a COVID angle. And I think COVID research, it sounds awful to say, it's something we've had to actually start playing the COVID card. As long as we can actually say that something has a relevance to COVID, then that's okay. But if it's non-COVID, that's certainly not as important. I think Tom mentioned the challenge of sort of healthcare backlogs. And certainly there was, there is concern that perhaps the other way, that the obsession with sort of getting the waiting lists back down again will actually mean that certainly care aspects and research aspects perhaps really don't get the priority that they equally need. I'm all for getting waiting lists down, but just getting it so that you can say that you can get a waiting list down very easily by just seeing everybody for 5 minutes and then discharging them. It's perhaps we need to make sure that the emphasis doesn't become completely obsessed with COVID and the impact of COVID. And there are still 750,000 people with dementia who need actually research, intervention, care, cure, whatever, as well as obviously managing COVID properly.
It's a point well made. I believe, Emerald, you have a question, is that correct?
Yes, thank you. This is directed at anyone, but it's I guess from a slightly different perspective of a relative's point of view. If inspections have been kind of on video since the pandemic has been going on, and if relatives haven't been able to visit, how much of a patient's deterioration can we put down to the stimulus they haven't been getting from relatives visiting? Because if a patient's been used to having daily visits from their relatives and that's suddenly gone down to 0. And as you said, obviously, care homes have been inundated with work and staff turnover. They may have not have noticed the deterioration as rapidly. So yeah, how much can we put down their deterioration to not having the stimulus?
Could I ask one of our speakers to respond to that? Tony, you're muted, I'm afraid.
Yeah, shall I go first then?
Okay.
Yeah, well, it's clearly enormous effect. A problem perhaps in studies that were ongoing, longitudinal studies following patients over time, where one was trying to find the natural course of dementia, and clearly even people, the many people with dementia and carers who've managed to escape dementia. Yes, the isolation, the change in routine has obviously had an enormous effect. So I think longitudinal natural history studies have had a very major problem. In studies where you're comparing two groups, drug trials, randomized control trials, hopefully the impact of COVID restrictions and so on are similar in the two groups, and so it might come out in the wash at the end. But it does mean that large numbers of the studies that were up and going and ticking over pretty well a year ago, those that have struggled to continue, it's going to be a real challenge to interpret the results. And I guess it's 1 or 2 years of non-COVID natural history research, dementia research, that's going to be lost.
Thank you, Tony. Does anybody, do either of the two participants want to comment on that particular question? Tom?
I suppose I could just say, I mean, it's going to be very hard, I think, to know on an individual basis the proportion of impact that isolation is going to have had. Video calls and telephone calls clearly are beneficial and do to some extent mitigate against the lack of face-to-face interaction, but very difficult to know. And as was just being discussed, I think from a research point of view, this could have a big impact on some of these longer term trials. Hopefully the randomized trials not so much. From a personal point of view, it's just very difficult to see someone deteriorating without that interaction. The situation we're all stuck in still to a degree at the moment, although slightly better than it was, I suppose.
Yeah, I mean, I'm not a clinician, so I'm not sure about the impact on certain individuals, but we know how important in-person contact is to people with dementia, particularly those in care homes. just even just sort of a few minutes a day of kind of good quality interaction is hugely beneficial. I don't know, I mean, it's a rapidly evolving area. I don't know whether the research is being done yet to compare whether video calls offer any kind of enough of a replacement to in-person. I mean, perhaps not. I mean, just thinking on a personal basis, it doesn't do it for me. Zoom calls all day, so I doubt somebody with dementia would entirely replace in-person. But it's probably important to find out to what extent it does.
Can I ask another question, please, which is one that goes beyond dementia research, and certainly an area that I'm as a research scientist and particularly interested in or worried by, which is the impact on our future researchers because of the funding situation that we have now, and also the morale amongst the research community, the impediments to research and to their future careers. So I'd be really interested to hear what thoughts you have in this area.
I mean, I think we've some colleagues of mine on sort of postdoc jobs, which are these are the jobs that you would have after your PhD, are typically short-term contracts. Just in case there's anyone in the audience who doesn't know, those, I think I know some projects that have just been completely stopped. Those that were intended to take part in care homes actually was one example, and obviously the impact there is potentially devastating for that part of the research community. I was reflecting a little bit during the talks, and I think one thing we do lose is just being in an office together and sharing ideas spontaneously. There's only so much I think that Zoom calls can replace there. I think that affects morale, and it affects your ability to understand what your colleagues are doing, and just that general idea of knowing what everyone's up to. And I think that's really important as an early career researcher, just to network, to see people in person and to have those conversations off the cuff.
Yeah.
And then lastly, we've tried to recruit to a couple of positions in the last year, and it's been really tough. I hadn't realised that how many applications we have from abroad, for example, and so we did really struggle with recruiting to kind of more junior positions for a couple of jobs, and we've had to delay start dates as well, for example.
Yeah.
Yeah,
we've experienced similar things with recruitment, Byron. So that's interesting to hear, although worrying. Right, I've got two people who want to ask questions. One is Kelvin Whelan. Kelvin has his hand up. Emma, do you need to unmute? Okay, go ahead, Kelvin.
Right. Yes, my question is about going forward. How is Brace going to promote the Alzheimer's research to ethnic minorities? Because we know that ethnic minorities have stigma about mental health, and I'm looking at two things. Firstly, promoting Brace as an organisation, and as well as that, getting donations from ethnic minorities, because I'm looking at the issue about how is it going to be promoted in a positive way that I can go out and promote it, so that people, when they see your leaflets, and that they can see, yes, they are interested in our ethnicity, our culture, our spiritual, our faith issues. Because I'm not really sure when it comes to that side of it, what Brace's outcomes and what they're looking for to go forward.
Thank you very much for your question, Kelvin. It's a very important one indeed. I'm going to back this over to Mark Porch in the first instance. Mark, sorry to put you on the spot here, but if you'd like to comment on Kelvin's question.
Yeah, thank you. I've been temporarily spotlit to deal with that one, because it is very much to do with Brace policy rather than the other issues raised. It's a very important question. We are actually working quite hard to to connect with a range of ethnic minority communities, mainly in Bristol, because that's where we're based, and we're small, so our reach is limited. I am a member of something called the Bristol BAME Dementia Working Group, and its meetings have been rather disrupted by COVID over the last year. We normally meet in person, and much of the work that it is trying to do is community-based, and therefore involves physical meetings. So that has been held up, but Grace is very much engaged with that. We are very, very keen to make sure that the sort of information that we're able to share at meetings like this, at webinars and public meetings, is getting through to as many communities as possible, because there are often cultural or translation issues that disrupt the flow of information. Not all communities, I'm aware, are getting the full benefit of information about dementia, or sometimes have difficulty accessing services. So it is something we're working on. I can't give a more helpful answer than that at the moment, other than that we are very much engaged with that. And one of my colleagues, Amanda, who's here, is currently working on a webinar. I can't remember when it is, in a few weeks' time, with an organisation that is trying to make dementia care more appropriate to people from some African Caribbean backgrounds who are finding that a lot of care is not suited to their culture. So these are issues that we're very much aware of.
Kelvin,
Mark, can I ask you one more? Excuse me. Can I just ask one more question, and I promise I will keep quiet. When you said about going forward, can I ask, will you be doing any information in other than English? Because I'm a carers consultant for a mental health organisation, and my role is about supporting the unpaid care of dementia. And one of the issues we have is people say, well, though I can speak English, I can't read and write English. So they don't engage, shall we say, in these kind of groups. So I'm just looking forward about now, is the only information you're going to promote being in English written I'm looking at?
The short answer to that is we'd very much like to be able to translate into some other languages. The long answer to that is a very long answer, and perhaps you and I could have a conversation offline, because it otherwise might take quite a lot of this webinar away from the issue of COVID, but I'd be very keen to discuss that with you.
Okay, so we've opened a line of communication there, so thanks to both of you. Now, I know that Nicola has been waiting, but before I go to Nicola, could I go to Rosa Hughes, chair of the Bain Dementia Working Group, because she would like to add to something that Mark has said. So, Rosa.
Hi, thank you, Bridget. I'm sorry. Yes, Mark just mentioned about the working group for BAME community, and about 7 and 8 years ago, my involvement on the APPG on dementia, working directly with Baroness Sally Greengross, who was the sole chair of the APPG, all-party parliamentary group, for those who do not understand what APPG stands for, on dementia in the House of Commons. And I work directly, very closely with Alzheimer's Research UK, as well as Alzheimer's UK. That's why I was invited to join the group and sit on behalf of the BME community. At the time, I'm also the vice chair of a BME Elders Forum, HUK National, not Bristol, BME vice chair for the Older People Forum. That's why I was really playing very important role. And as a result, I was attending the meeting. I found out we have a lot of every meetings, we had at least 2 professors presenting a lot of research presentation and all this report. None of them actually related, Kelvin quite right, none of them actually related to any BAME community. At that time it's called BME anyway. So I challenged the committee, definitely, who was with 5 vice chair, they're all familiar faces on the telly, MPs as well. And I'm sure I was the only voice there, very, very isolated, very lonely. But then deterred me, I actually challenged. I said, how come I never heard anything being mentioned about the needs of the people living with dementia in the BME community, especially the carers, you know, they're really struggling, but not being recognized at all, or their hardships not being noticed. As a result, they apologize profoundly. And Baroness Sally Greengross, definitely after I had consultation with her, she supported me profoundly. And you know, I started with the research. I came back and I asked the mayor then, George Ferguson, whether he would like to bring them, because I need his money support as well. So that's how it started. And we actually, next thing is Professor Rick Cheston from University of Bristol, UWE, actually been assigned to me to work with me directly. And that started, and we had a very humble beginning for Chinese community, but I recognized that was not good enough because we need to cover the 3 largest oldest community, minority who came to this country, which are South Asian, Afro-Caribbean, and Chinese. They are the longest serving, you know, every minority in this country. They are now getting old. They came here because of labor gap, and now they are getting on a bit. So they deserve really to be recognized, the contribution they made.
It's a very important point that you raised, Rosa, and thank you very much for your efforts in this area. Have any of our speakers got anything they'd like to respond to Rosa with before I move on to the next question? Tony?
Yeah, no, I absolutely echo it. I find that over the last couple of years, your attention is often being drawn to the particular challenges and the needs of different ethnic minorities. But I very rarely see any research on actually doing anything about it.
Yeah.
In what interventions might or might not work. And so I suppose as a researcher, you should become back that I should be doing it. But I think there really is a need for intervention research about you know, what interventions are most helpful in one community or another, rather than endless descriptions of the particular problems. And I'm just very aware of it because I was sent yesterday yet another report to Welsh Government about the particular needs of BAME population and dementia, which was describing all the problems but not coming up with any solutions. It's not so. It's not unique to England. It's also in Wales as well.
Okay, so thank you very much for that, Tony. Now, I have a question from Nicola, and also I'm being challenged by the IT at the moment. Nicola, I'm assuming it's you that's also said you don't have access to a microphone, in which case I will ask your question for you. So what Nicola's question is, it's the possibility of funding technology to help bridge the digital divide for people with dementia and in research. In the same way, Nicola notes that there have been efforts to do so with children with home learning. So do any of our speakers, and Mark, do you have any insight into this, or any of our speakers into provision for IT resource to bridge that gap? I'm not getting an immediate response from anybody.
I think the silence says it all.
Well, quite. I've got Tony and then Tom.
What has happened is the fact that suddenly a lot of tablets have appeared within nursing homes, care homes, and on hospital wards as a means of communicating between patients, residents, and the outside world. And so I know in the University Hospital Wales, which has, I think, 800 beds plus extra 400 for COVID, I think there were 600 tablets have suddenly appeared. So at least within care homes and within the hostel environments, there is now technology available. I would absolutely echo that outside hospital, yeah, I'm all for children getting free laptops for to help with education, but actually tablets and teaching how to use them for some older people would be, yeah, well deserved, very welcome.
Thank you very much, Tony. Tom, did you have something to add to that?
I was going to say something very similar, but the only addition I would say is that we have, pre-COVID, were using tablet type technology for people as part of research studies, for part of the data gathering experience. Obviously, people with adequate training were then able to use them. So I think it's a good idea. It would be nice to see if it could be done a bit more widely, but there are obviously lots of potential barriers to that, not least the financial.
Byron, I see you're unmuted.
Yeah, just a really quick one. One of the studies that was in Clive's presentation is about creating kind of care that can be delivered digitally, or interactions with people with dementia that can be delivered digitally. But I don't. One of the problems you often have with that type of research into psychological interventions is it actually getting rolled out. So you can show something that works in a research study, then the funding to get that rolled out that might be dependent on technology and that sort of thing is often the challenge. And I don't have an answer to that, but just to raise it. Yeah.
Yes, thank you for raising that, Byron. I have a question here, which is a follow-up really, which is looking at things from the other side of the coin in a way. It's whether there is a noted impact on Bain researchers in dementia. I don't know if anyone would like to comment on that. I can make a general comment about Bain researchers in STEM subjects, which is that the figures of researchers overall, never mind COVID, in STEM research doesn't represent. It's not an appropriate representation of the Bain community at large. And there's hard evidence to back that up. But I don't know if COVID has had a particular impact on that. I don't know if any of our speakers would like to comment. Okay, but certainly we've noted the question. It's probably very difficult to get that information, hard evidence to support that.
Bridget, you've got a question from Joanne Rice in the chat box. But she's also got her hand up if she'd like to ask the question.
Thank you very much. Joanne, would you like to ask the question yourself? Thank you, Joanne.
Yes, thank you. I am a manager of the Dementia Support Service in Milton Keynes and in West Bartlett and Reading. And we've noticed that the diagnosis rates are falling across the country. And memory clinics are seeing patients with more complex presentations when they do come to diagnosis. Does Brace have any plans to contribute to a COVID recovery plan, or to do any studies to help to identify how people can regain lost skills or confidence, or how to boost the diagnosis rates, as we know that obviously access to support only comes after a diagnosis?
Would any of our speakers like to comment on that?
Okay, shall I say, I guess the reason that diagnosis rates have reduced is the same reason as the waiting lists have gone up, in that clinics to make the diagnoses haven't been open, haven't been able to see people. Even then, when they have reopened, they can't see as many people because of COVID restrictions. So there are fewer staff available to make the diagnoses because they're busy doing other things. And also, it's back up now, but certainly in the second half of last year, we had about 2/3 the numbers of people being referred that we would normally expect. So people are not going to their GPs and or the GPs are not referring. So I would hope that as things get back into a more of a routine, that the numbers will go up, but there's going to be a backlog. And so to some extent, we're back where we were 2 or 3 years ago.
Thank you very much, Tony. I see a hand up there from James Grasham.
Hello, yes. First of all, I work at Joint Dementia Research, so that just a bit of context there. And we have a few studies from Brace on JDR. One of the things people mention about the Bain community, there's been a couple of studies with ourselves and with Alzheimer's Society looking at the Bain community there and about the different interventions, but and sometimes you find there is members of the Bain community looking at those studies, so that there are some, but they're relatively small numbers there. And part of the problem is the number of volunteers, because just generally, as I'm not sure if the researchers have found this as well, it's just very difficult getting members of the Bain community in the first place to take part, which would then relate to the thing that I was going to primarily be asking about. Do you think that with the COVID vaccine trials, etc., this is going to encourage more people to take part in research, which might help research going forward?
Do we have comments from any of the speakers here on this topic? Byron?
Yeah, I can comment generally about, I mean, I've not been involved in any, not sure I would know about the COVID vaccine and the implications on participation in other research, but in terms of recruitment of very different ethnicities to research, I think I think we've got a big research study going at Exeter called Protect, and there's 25,000 people enrolled, and we just recruit through general publicity really, but we have 98% white British people, and we're obviously not doing something right, and not to reach other ethnicities, and I think that's a big problem. It's not just a problem we have, but lots of other research studies I've been involved in have had the same problem.
I don't know if Tom or Tony wants to share any experiences here or any thoughts on this. Tom.
We hope that the publicity around vaccine trials and people volunteering to take part in that just will raise people's awareness of ongoing research, and the hope would be that might pique people's interest and perhaps make people more aware that all of this activity is going on. Again, it's difficult to comment on a portion of people from different ethnic backgrounds and participation in studies. I know my colleague Samra Ahmed, who sits on the BGS panel with myself, looking at the research side of things there, is keen to do a lot more work on that front. So I hope there will be more coming through, specifically looking at people with dementia.
Thank you, Tom. Okay, I have a follow-up comment from Emma Richards here about the diagnosis rates, and just to tell you, she commented that they've been reduced, in her view, because people have been told not to overburden the NHS unless there is an emergency, which I'm sure other people would perhaps agree with there. I'm just looking down the list in the chat line. Emma, Amanda, is there any questions that I've missed at the moment you'd like to highlight?
I think James would like to come back.
James, you want to come back, and I think Kelvin after that. James.
I didn't realise I still left my hand up, but oh no!
but given the opportunity,
yes, but given the opportunity, yes, they're right, and I think that the big problem is actually getting members of the BAME community to get involved in, to get recruited in the first place, and it becomes a bit of a chicken and an egg. You can have a lot of studies if you've not got very members of the group to take part in the studies, which makes it harder between the two. So hopefully, because every group that I talk to, we all have the same discussions about trying to get more members of the BAME community involved going forward.
Thank you for those thoughts. Now, I think I'll reserve the last. We're sort of running out of time here, so I'll reserve the last question for Kelvin, and I'll do some summing up.
Thank you, Byron. Can I ask you a question? But this isn't trying to be racist or ignorant, so I apologise before I ask this one. Do you get involved in carer centres when you're talking about your organisations? Because carer centres have people with dementias. And I think going through the carer sometimes, in a way, going through a carer's organisation, because I do this myself, maybe would be a good way of promoting your organisations. Because when you said about organisations, I'm not really sure in the way of how you are promoting your organisation and where are you going with your organisations to promote it.
So the study, so jump in if I've misunderstood you, but the study I was talking about a minute ago was one called, it was a research study called Protect, and for that study we're actually recruiting people who don't have dementia because we're interested in risk factors for developing dementia, but it's nonetheless critical that we up our recruitment of other ethnicities because different risk factors will impact different ethnic groups differently, I would think, or we certainly need to find out if they do. And that's what I was saying. Sorry, carry on. Sorry. And what we're doing is we're partnered with King's College in London, who are based in South London, and so they are undertaking some work there to increase awareness and recruitment to the study and other dementia research as well, actually. And they've got, let's say they've got a few more channels, I think, being based in that particular area of South London to kind of be closer to the communities. They're in the community, literally. So so we're hoping we can do something there, but it's something we're working on.
Okay, we get a thumbs up from Kelvin there. So I think we're approaching 12:30, so I am going to draw things to a close. But before I do, of course, I very much want to thank our participants today. Thank you for your presentations, which were very insightful, and also making yourself available to address some of the important questions that have come from our participants, which of course reminds me to thank the participants for coming along today to join in with this webinar on what is, of course, a very important topic. And then finally, I'm reminded by Amanda has posted on the chat line the BRACE website, and to remind people that they, if they wish, they can make a donation to dementia research if you follow the links in the website. And I just want to say a few words on this topic to finish off, because it's clear that the challenges facing dementia are multifaceted. But not least at a time when medical research is most needed, charities are facing unprecedented falls in income due to the ongoing pandemic. And it's had an immediate and devastating impact on medical research charities. It's put an end to mass fundraising events, which has forced charities to cut funding on research. And as chair of our scientific advisory committee, from personal experience, I can assure you that that is indeed the case. And BRACE's spending on research and informing the public about dementia fell by over 40% in the last 12 months. But you all can help. We all can help. So please donate. You can organise a fundraiser or do what you can to highlight the situation to all those you know who care about dementia research. And perhaps the final word, this event was brought to you free today. And please consider donating by visiting the BRACE website. And the address, as I say, is in the chat box. So thank you very much to everybody. I found it incredibly informative today, and I thank the presenters again for their time today. I know they all have busy schedules. Okay, so thank you and goodbye.